So is red light the new eye health miracle? There's been a ton of research coming out in the form of red light therapy, more formally known as photobiomodulation or low-level light therapy. And the eyes have been a major area of focus because there's evidence and new devices now using this type of therapy specifically for treatment of eye conditions like dry eye disease, age-related macular degeneration, myopia, and many others. But I'll be honest, myself, I've been diving into this research for the last several years, and the more I read, I honestly end up having more questions. Things like, what wavelength is ideal? How often it should be used? What is the energy dosage? And, should you be treating with the eyes open or with the eyes closed? So today, here on the Dr. Eye Health Podcast, to help us break down fact from fiction, we have Dr. Dotson. Dr. Robert Dotson is an ophthalmologist with over 40 years experience in medical device research, with over 20 years specifically in that of photobiomodulation, applying to ophthalmology. He's also a co-founder of several companies, including that of Photospectra, as well as Lumathera, which, if you're in the eye care space, you may be familiar with that name, as they are the first company to have a photobiomodulation device, US FDA approved, for the treatment of age-related macular degeneration. And today, Dr. Dotson helps us break down how this low-level light therapy truly affects the ocular tissues, how it's evolved over the last 20 years, and more specific insights into devices, into wavelengths, power density, safety, and other important topics. So I want to take a moment to talk about at-home red light or low-level light therapy devices, especially for use around the eyes, because this is something I get asked about all the time. And to be honest, this has been an area where I've had a lot of hesitation. There's just a ton of devices online, and many of them are not really transparent about their wavelength, their energy output, or how they're even truly designed. And when we're talking about using light around the eyes, I think that level of precision and safety does really matter. That's why I have been very cautious about what I personally use and what I even feel comfortable talking about here online. Now, what's interesting is that in this episode, Dr. Dotson brings up the Arunalite device on his own. That actually wasn't planned. This episode was recorded before Arunalite even came on as a sponsor. But Dr. Dotson, bringing it up, I think does speak to the level of research and credibility behind it. Now, in today's episode, we're, of course, going to be sharing a lot of information about what's in the research, as well as what's working in patient care. But I do want to give that disclaimer that this information is all wellness information and is not a replacement for your doctor's care. Before we dive into the episode, I just want to acknowledge Arunalite as a paid sponsor and supporter of the podcast. We'll be talking about wavelength and specifics around the Arunalite device later on, but for now, just a quick mention and thank you to Arunalite for helping make this conversation possible. Let me just start off asking you, Dr. Dotson, can you share kind of how you first found red light or photobiomodulation? How did you first get introduced to it? How did you dive into it? All of that.
I graduated from University of Tennessee, Memphis, in med school in 1974 and ended up doing an internship, residency there. And at that time, I was fascinated by intraocular lens implants. That was my thing, and early phacoemulsification. One of my mentors who I really admired introduced me to all the early implant guys. I patented some instruments myself, so I was always kind of had an engineering leaning character. And in 2000, I was in private practice by then. I was looking at adding aesthetics as a component to my refractive surgery and cataract practice, as another way to have an income stream. And one of the sales guys brought in a device made by Light Bioscience called Gentle Waves. And Gentle Waves is a yellow wavelength, and it basically would treat the whole face and reverse some of the aging changes like wrinkles, that kind of thing, decrease inflammation. So he brought this thing in, set it up. The treatment was 35 seconds of flashing yellow light, which I couldn't believe this would do anything, okay? But I said, okay, we'll leave it and we'll try it, Well, lo and behold, I had patients use this thing, and they could tell a difference in their skin with one treatment. Even family members would remark on it. So I thought, no, this is this is beyond crazy. So I started looking into phototherapy and light therapy, and I found out that really this is nothing particularly new. I mean, it goes back many centuries. Light and color wavelengths and things has been used. And so I began to play with using different wavelengths for treating eye conditions, because that's what I was, of course, focused on. I had spent several years trying to recruit fellow ophthalmologists, especially with retina people, to help me research some of the applications like for macular degeneration. And I was introduced to Graham. Graham got it. So he and I got together and we set up a formal study for dry macular degeneration, because at the time there just wasn't, and there's still not any great solution for that, but there was nothing except maybe vitamins and lifestyle changes, that kind of thing. So we demonstrated in our first study that by using a certain combination of red and yellow and near-infrared wavelengths, we could actually improve vision some and reverse some of the aging changes you see with dry macular degeneration. So, seg forward to 2013, Graham had gone to Australia to present our paper that we made. He was seen and heard by Clark Tedford, who was a PharmD, PhD pharmaceutical guy. And he had been involved in biophotonics for stroke, but he was looking for things to do. He was impressed with the technology, but he heard Graham give this talk. And so when we returned to the States, he was looking for me. What turned out that I was in Seattle at the time, and he was just 15 miles away in Paulsbo, Washington. So we got together and we started a company called Lumathera. And Clark had the pharmaceutical and research background to help put this into a device which could get through the FDA, and we could get the proper studies to make, to make that happen. So that's how we got there.
Thank you for sharing that kind of background. I think right now a lot of people are coming into seeing red light, right? They're first introduced to this because they maybe have seen an advertisement online, maybe in their social media, for like a red light mask for their face, for their skin.
Sure.
Or, maybe for muscle recovery, because a lot of people who are athletes, maybe you'll even see a red light device at their gym. So could you think in a nutshell, for everybody who's just kind of like, they've kind of heard of this, they don't really understand what it is, could you explain just in a nutshell what red light therapy or photobiomodulation really is?
It's really more than red light. It's even white light can produce tremendous biologic effects, full spectrum type things. I saw some studies out of the Soviet Union from the 60s, and they used white light transdermally to treat high blood flow areas, and it would affect all manner of blood parameters for weeks, one treatment, okay? There's a lot there that we don't fully understand, and of course, the use of light and colors and that kind of thing has been around since at least ancient Chinese and Indian times, all the way up till today. What specific wavelengths do is they actually work at a cellular level, and depending on the light dose, which can be wavelength, time of exposure, the intensity of the light, all those parameters, whether it's pulse or continuous wave, those kind of things, All those things can both up and down regulate maybe 140, 150 genes that we know of. So you can switch on and off inflammation with a proper dose, if you will, of light. And our natural cells, and everybody walking around produces biophotons, and those tend to be within the kind of the same range. So think about that, your own cells are producing photons that help regulate chemical function and intercellular communication. So when you put in that right key of light, you can switch on and off healing mechanisms without the side effects of pharmaceuticals and all that kind of stuff. Mm-hmm. So basically what you're doing is, I think, is you're modulating a cell's own encoded ability to heal itself, because every cell in our body, it knows what it is, it knows how to heal itself, it knows how to give up the ghost when it needs to and move on, make room for new ones, So mainstream medicine is kind of more focused on treating symptoms of a collection of cells, our body, than how do we make those cells function better. So light is one therapy.
I know in a lot of the research that I've been reading in on, either for specific application in eye care, but also in just the body, they often do reference at least the mitochondria and the influence that these types of red light or near infrared light may kind of boost the ATP production from the mitochondria.
Yes, and that's the main function of the red near infrared wavelengths. It really ramps up mitochondrial function and mitochondrial numbers in a cell. So it really can boost ATP production, 100, 200%. So it's pretty remarkable. But you could also switch on and off all sorts of genes with it, like regulatory genes.
I was going to say, it seems like there's kind of a long-lasting effect with it too, right? You get, like you said, even one treatment, and it can have a sustained effect.
Weeks can last weeks. So it does better in all the devices that we've used, if you can do a series of them, within a couple of weeks. I think Limothera, I don't know what they ended up with because I've been away from the company, but they're based around like 3 treatments a week for 2 or 3 weeks, and then repeat that in 3 to 6 months. Mm-hmm. But we followed with our little studies, Graham and I mean, the effects lasted out past a year from one series. So that's pretty remarkable. It begins to fade at 3 to 6 months typically, but it never goes back to the starting point. Isn't that wild?
There's so many questions I have, because I've just loved reading into this research, and even specifically on like the red light devices being like that was approved with the Limothera device by the FDA for treatment of dry macular degeneration. And I definitely want to dive into that. I think before we kind of get into the specifics about, why, how many treatments, how far they're spaced apart, what that may make a difference with, like you said, like there's red light, there's near infrared light, there's yellow light. Mm-hmm. Some devices have blue light too. I believe that's more for like the surface of the skin for like acne and things like that. Do you have any kind of quick explanation of like what these different colors or wavelengths specifically may be beneficial for?
The blue wavelengths are shorter wavelengths towards, ultraviolet down that direction. And those tend to be very energetic photons compared to a long wavelength red. And they don't penetrate very far on skin, unlike a near infrared. Some of those will penetrate several centimeters, even transcranially. So blue light kind of arrests at the surface, and it does have antibacterial, antivirucidal, some anti-inflammatory effects. a man named Pleasanton, who was, I think he was a Union officer, actually in the 1870s. He used blue light for wound healing, like a blue filter over a light source. Yellow light, we found, and that came out of the Gentle Waves device, but that was developed by Dr. McDaniels, David McDaniels, who's a dermatologist in Virginia Beach. And he found that it would boost new collagen production and reverse collagenase, which breaks down collagen. So it does affect skin, but it seems to prevent VEGF, vascular endothelial growth factor. So it seems to switch off neovascularization, which is big for retina, see.
Yeah, that's huge for the eye.
Isn't that wild? So if we could get away from using injections in everybody, it'd be nice.
I know several publications have kind of commented that the combination of doing several of these lights either at the same time, these wavelengths at the same time, or very close to each other in time frame. In fact, the same device, the Lumathera device.
It does. Lumathera uses 3 wavelengths, and it sequences those in a pulsing fashion in a short period of time, and that does seem to be more effective than any individual wavelength. They appear to be synergistic, and they do seem to hit different targets within the cell. So that's why we ended up in Lumathera using the 3 wavelengths.
Yeah, and it seems like some of the early studies now coming out on using that for like diabetic retinopathy maybe is more favorable than just red wavelengths alone.
Yes, yeah, it's almost identical pathologic problem as macular degeneration, so it reacts very similarly, and I think it will be approved for diabetic retinopathy at some point. But you got to do the studies, you got to get past the FDA, and even more than that, you have to convince all the retinologists. which may be even harder than the FDA people.
Again, I think there's a good slice that so many of the doctors are, especially in ophthalmology, and I think are probably some of the most skeptical doctors I've ever met.
Absolutely.
It's not necessarily a bad thing, but it also, like when it comes to, like you said, innovation, it maybe does hold us back a few years. I mean, oftentimes we do see a lot of treatments develop in Europe before they come to the US, like sometimes by a decade.
I started my career in ophthalmology, like I said, in our 70s, and my mentor, he was doing phacoemulsifications in the early 70s. And doing implants, doing Benkhorst implants and Choice and all those guys. And he caught hell. I mean, he caught hell from the local ophthalmology committee. Within 5 years, they were all doing it, okay, trying to do it anyway. So now it's an everyday thing, you know, everybody and their grandma does phacoemulsification implant.
Yeah.
Nobody remembers the pioneers. When I was teaching residents, I'd talk about meeting some of the old implant people, and they hadn't heard of any of them, which blows my mind, you know.
Right. I know, going back to the red light, so I think a huge thing that is always, I think, difficult to understand for people who aren't like studying red light, because all they hear about is red light, and they hear maybe near infrared light, and they're thinking, you know, specific wavelength. They hear 660, 670, or 630.
Right.
But there's more to it, right? Like you said, the power that is put behind this light can change it from being safe to potentially damaging to tissue.
Right. Yeah.
And in the study of it, I've read across what's called the biphasic dose response curve, which is, do you think you could kind of explain what that is?
Yes,
and how that translates
it's a lot like a pharmaceutical product, in that there is a sweet spot, and when you don't get a high enough dose of photons, or you get too much, then you don't get the effect that you want. So there is a sweet spot, and that's part of what the research has to be directed at, is to determine that. So it tends to be in the red, near infrared, like between maybe 2 to 4 joules per treatment. So if you get above that, you do get untoward effects in some cases. We use, I think it's best to use LEDs for eye kind of stuff, because that's non-coherent light, and so you don't run the risk of thermal damage and really high powered density that you do with a laser. That's the problem with using a laser around the eyes for anything other than cutting or burning something. So most of the eye-safe kind of devices will be LED based.
A big question I think a lot of people always ask is about general sunlight, right? Because I came across a study from the 1980s that did show that, through the human eyelid, the light that penetrates from natural sunlight is in the 600 nanometers and above. And it makes sense, right? You close your eyelids, and if you look toward the sun with just natural sunlight in your face, you can see the red coming through your eyelids. But I kind of wonder, if you were able to mitigate UV light exposure, because we have to worry about UV light from the sun. But do you have any idea of like how much just, if you were just to go outside on like a summer day, like, do you have any idea how much just various wavelength dosage you would get from that?
Yes, here's the thing, the globe is rotating, so early morning and evening, we get a lot of red. High noon, you're getting maximal UV. So that would be the time to avoid, sunbathing at high noon. And obviously you would want to limit exposure to sub-burning threshold, whatever that is. But this is certainly known in humanity going back thousands of years. Hindus, some Buddhists, they have a morning greeting the sun kind of thing, and it's supposed to energize and recognize the sun. But when you think about it, see, that's really just a phototherapy-based kind of thing, because they're getting maximal red light. So that energizes them and that kind of thing.
I've gone to tell people, because solar retinopathy, when people do stare directly into the sun, right? That's
a bad idea.
Yeah, that's a bad idea. That'll burn a hole in the retina. But people have often asked me, like, hey, can I, I've heard about this, or they've said like, hey, is it okay if I, look toward, not directly at the sun, but, toward the sunrise or toward the sunset? And I've started to say, like, it's just the UV light index is really far down at that point. And as long as you don't stare directly at it, you're probably going to be just fine. And you'll probably have a calming effect, or maybe a nice experience in the morning watching the sunrise.
Right.
As far as as a true health benefit to the eye, I don't have that data, but it's probably not going to hurt.
Yeah. It's just, I would not stare at a solar eclipse or high noon into the sun, okay?
Yeah, definitely
because
not.
then you get into thermal issues, and especially if you're wearing glasses or they're hyperopic, for instance, you're wearing glasses. Burn a hole right through their retina.
So, like you said, kind of this 2 to 4 joules is kind of right now what a lot of the data is showing is kind of the therapeutic, most beneficial. Going over the 4 joules in a treatment session might be too much. Going under that may not have a beneficial effect. Does that sound about right?
That's correct. And what is too much? We don't know, but it would have to be very, very high with an LED device. At some point, you will get into thermal damage with that, especially the longer wavelengths, like a glass blower's cataract. I don't know if you know what those are. So these long wavelengths, you can begin to get thermal effect at the retina. So that could be an issue.
In the eye clinic, we now have at least published data from things like the Lumathera device. And there's some other products that are kind of other competitor products that have largely been designed for like skin treatments.
Yeah.
That I think some companies are experimenting now, saying, okay, well, let's have people do this for macular degeneration and see if there's a benefit. I think my big question is, I want to better understand the various parameters, even myself, like the variables, because energy is one thing, but then, like you said, there's sometimes pulsing. And some of these procedures will be like, hey, we have the eyes closed, we do a constant light, and then their eyes are open, then we do a pulsed light.
Right.
Do you understand, or can you give me any reason why?
I think it's probably beneficial in some of these to have a pulse to it, because it's like driving. It seems to drive photons better because cells resonate. You get into the resonation of the individual cells too, which we need AI to figure all this out, for us. But so pulsing, it does seem to give cells and the organelles within a cell a chance to recover from vibration. And so you get almost like a driving effect when you pulse it. Having said that, continuous wave works fine too. It's just, this is speaking only of LED type devices, not with lasers. Because people will say, well, if that's LED is great, then a surface laser would be even better. So, which is not a good idea, because you get into coherent light and you can get really high energy levels and really bad thermal effects.
So how about with the eyes open or the eyes closed? Because even with the Lumathera device, there's a moment with the eyes closed and another different lights used when the eyes are open. Is there any reasoning behind that?
It's mainly based on the way that the base research was done. And it with the eyes closed, you're getting a reduced and more homogenized, if you will, light wave to the retina. So, you close your eyelids, you're knocking out about 90% of light transmission.
Right. So is it a way, like, you can kind of say, if your eyes are open and you're staring at the light, you're getting a really intense treatment through the pupil to land?
Yeah, I'm not sure it really makes that much of a difference.
Okay.
I know I've got an Aruna light. An Aruna light, basically, see, this Graham Mary really is the brains behind this, my partner from Canada. And
yeah, I've actually got a couple of those I've been testing out.
Yeah, it's based on our original research, except it doesn't pulse or anything, and it's a single wavelength because we have patent issues. So, but this is a safe, decent device, and you could use this open eye, but closed eye device is okay too. I've done both. I use mine a few times a week. I think maybe it helps with brain stuff, because you're sending photons basically straight into your visual cortex and intracranially.
Personally, I have been using the Aruna light for close to 2 years. I first found the Aruna light when I was researching and looking up the most credible at-home low-level light therapy devices for use around the eyes. And the Aruna light happened to be designed with input from not only PhD researchers, but optometrists, ophthalmologists, even retina specialists. It's Health Canada approved and FDA listed. The Aruna light uses 670 nanometer red light, which is one of the most well-studied wavelengths for reaching retinal cells and supporting mitochondrial function. Something that I appreciate about the Aruna light is simply just its simplicity. The treatment only takes about 3 minutes. It's hands-free and it's easy to stay consistent with. Now, I do want to be very clear. At-home devices are not the same as in-office treatments offered by your eye doctor. The Aruna light is a wellness device and is not a replacement for your eye doctor's care or for the treatment of any specific disease. But I think if someone is specifically looking for an at-home red light device designed for use around the eyes, this is currently the one I personally have the most confidence in. If you want to learn more, you can check out the Arunalite website, and if you decide to try it, you can use the code DrEyeHealth 10% to save 10% off. Now, let's dive back into the episode. And I've seen some different devices in the red light space at brain injury rehab meeting conventions.
Yes.
And I think, with the same right as ophthalmology, there's some skepticism even in that space, but some of the smaller studies that are coming out show positive effects, whether it be studied short term, but it's
been used for affective and mood disorders, mental health kind of things. It does seem to help with depression, all sorts of different applications. And the man that was CEO for Lumathera, his previous company was Photothera. They were based in Florida, and they were doing transcranial photobiomodulation for stroke. That's really a difficult thing to tackle because there's so many variables in a stroke patient.
True. Every case is a very individual case, right? You can't bundle them together.
They just could never get any good data, you could use to forward it, even though I'm certain it works and helps. Right. But unfortunately, the way FDA and device stuff is in this country, you have to prove it with these controlled studies, and you can't go with anecdotal stuff. So,
being that you mentioned the Arunalite, I think this is a good question because of all the various devices that are sold online or at home, whether they're specifically marketed to be safe for the eyes, or just other devices, right? Because a lot of people may already have a device for their face, for their skin. I was going to say, are there risks? Do you have safety concerns of some of these devices, of people abusing them, using them maybe too often?
Possibly. The problem is there's no standard for any of these things. So I work in the cannabis medicine now. So it's a similar issue. Within medical cannabis, we have known regulated products. Outside of that, though, God only knows what you're dealing with. The same kind of thing with this. So unless it has some type of certification by an FDA or a regulatory body from someplace else where you can look at this device and say it does this, then I would be very careful about using anything on the eyes.
Right.
Does that make sense?
Yeah, it does. Because I know, again, the more I've been trying to read and study this for a few years to really better understand it. And a common question people ask are like, hey, what device can I just use my skin device on the eyes? And I'm like, well, I don't know what the power density is. Even if the company gives a claim of how much power it is, I have no way of knowing that is truly what it's giving off.
Yeah, unless
quality control.
Absolutely, yeah. And that's therein is the problem with it. But theoretically, you could use a red LED brake light off of a truck and make a device out of it to treat yourself. I'm not recommending that, but
no.
if you have access to a physics lab and you can measure,
you said that sweet spot of 2 to 4 joules, right, in a treatment. I think a lot of the at-home devices are very low power. So in order to get that, you might have to sit under something for 6 hours. It's tough to say, right? It depends. Or a few days. It depends on the device. Where I know in the eye clinic, at least the several companies that are coming out with treatments for, let's say, dry eye. There's a few companies now, again, dabbling in macular degeneration, only that one that's been FDA approved just yet. But those devices, at least personally, I trust the manufacturer that what they're stating of the power of the device is truly what it is. Right. And I know the efficiency, the treatment time is only 15. So some of the dry eye treatments are 15 to 20 minutes. Right. But and then, of course, the macular degeneration treatment, the Lumathera one, that's less than 5. It's less than 5 minutes for a treatment. So that's kind of how I've been.
When we were using, when I had a Genowaves in the office, I was treating dry eye patients with it, and I got good results. Now that's a 35-second treatment.
Huh.
Usually I'd have them do maybe 3 treatments in a week and then come back when it starts to bother you again, that kind of thing. And I just gave it away. I didn't charge or anything. We had it sitting there and said, if you want to try this, come use this, and I followed.
Yeah. And now at least with the red light devices, there's publications of people like surgeons offering to do it before cataract surgery. And then after the cataract surgery, because they find that the rate of dry eye, the tear film parameters are significantly improved.
Yeah. I use, when I did cataract surgery and refractive surgery, I did every kind of refractive surgery thing, but I used one of these pre and post op. On the table, I would treat my cataract patients before I took them back and then do it after and in the office the next day. And you're
truly a pioneer in this, man. This is awesome.
Yeah, I'm a nut. But I do think it helps prevent CME, for instance, after cataract surgery and that kind of thing. So, and it speeds up healing time.
Yeah, that can make sense. I mean, thankfully, I do see Irvin gas or CME after surgery every once in a while, but I don't feel like I see it as much as I did when I was at the VA.
Because the surgery's gotten better. Back in extracapsular days before people were doing a lot of phacos, there's an awful lot of trauma compared to what it is now. And so I'm sure that induced inflammation resulted in more CME. And so that's gotten better anyway.
I think just to kind of comment back on safety, have you read much of all the studies for myopia that's been coming out using the repeated low-level red light therapies?
I haven't lately. I know people were looking at that. The Asian market, Chinese and Japanese are both have super high incidences of high myopia. And so I know that there are several research groups going on mainly in Asia that are looking at that.
Right.
I think it probably would be beneficial.
Yeah, it seems like from the several publications that have come out all around one device, the studies on kids who already are nearsighted, they're able to slow it down considerably, both axial length and refractive error. For kids who are pre-myopic, they haven't developed myopia yet, that also shows consistent data to slow it down. The unfortunate thing is that now there's safety data that have come out. Some kids have had vision loss, reduced rod or cone cell density in the macula. And then China even changed its laser or its classification for the device.
Yeah, it sounds it's a question then about the safety of the device probably. Are these laser based?
I think they are. I'll have to double check. Either way, I'm excited for that information. It sounds like we just haven't titrated out truly like a safety,
And there's lots of other things. I mean, glaucoma. I treated some glaucoma patients and was able to show a drop in intraocular pressure over extended periods of time and visual field improvement. So that needs to be pursued. I just never had the time and money to really do a controlled glaucoma study, but that's something that should be done.
There's a few small ones I'm aware of, and a lot of them are showing positive benefits for retinal ganglion cell health as probably the biggest factor. But yeah, like you said, let's talk about some of the benefits just for the eyes for our viewers and listeners. So certainly macular degeneration. That's where I think the vast majority of research has come out. And what's amazing for that I've found that just blew me away. When I first was reading it, I'm like, for dry macular degeneration, we don't have any other way to restore eyesight.
Right. I know. This is why you would think this would be to get the attention of every retina guy on the planet. But let me tell you, this is of the skeptics in ophthalmology, they're the worst for sure.
But from the publications that have come out around like the Lumathera device and a couple of the non-FDA approved devices right now, it does show treatment can improve at least one line in 50% of the participants, and up to like 3 lines in like 5% of the participants. So there's this range.
And the other thing is it prevents the deterioration you see without treatment. significantly. Instead of going down like this over for a period of time, it levels out. So
Right. So,
that's pretty impressive. You can decrease drusen volume and all that. We've shown that in multiple studies. I'm sure it's because increasing metabolic activity of the retinal cells, so they're able to clear out toxins and all the debris that goes with drusen and that kind of thing.
right. That's what people have asked me that. I had a patient yesterday ask me, like, they were listening in on a different podcast. They heard a different doctor talking about red light. And they asked, like, well, why is this beneficial for the eye? And I said, well, from what I believe and understand, is it because the retina has so much mitochondria within the tissues. It is such a highly metabolic tissue that it's, again, constantly having to clean up oxidized proteins and everything from just the chronic light exposure, right? Because it's working so hard. And then again, in some of these studies, they show improvement, like you mentioned, in drusen, right? The protein, basically the garbage protein that builds up when the RPE is dysfunctional.
That's correct. Yeah. So we showed significant reduction in drusen volume in several different studies. So drusen sometimes will just go away, but it's unusual, But we demonstrated, I think, pretty effectively that it can reverse some of these large drusen. And the biggest problem you see with that stuff, if that doesn't respond, is then you get into geographic atrophy of the retina, the macula, and some of that. Once you lose all those RPE cells and get a bunch of fibrosis, it's hard to come back from that.
Right. And I actually have some of the data here in front of me. The LightSight 2 trial showed about a 20% less geographic atrophy growth in the people using the red light or this photobiomodulation in macular degeneration. That's if not kind of on par or maybe a little bit better than some of the new injections.
There's nothing else that does that. That's what's crazy to me.
So yeah, it seems very promising. Definitely macular degeneration. I'm excited because we, again, other than supplements and lifestyle interventions, we haven't really had a way to slow down the disease.
It does help, but it doesn't give anything like these phototherapy type treatments. There's really nothing else out there. People keep playing with pharmaceuticals, chemicals, and all sorts of stuff. I don't think that's the answer. I think the answer is, in fact, this applies to medicine across the board, is to energize our own mechanisms to heal that particular issue. That's what we need to be focused on.
Thankfully, I feel like a lot of healthcare is transitioning. There's a little bit of a pivot point going on right now where I think a lot more people are recognizing. I think a lot of people are recognizing, hey, there's a problem with how our health industry has been structured. And a lot of doctors, it's like, one of my good friends, she went and got her medical degree, and she's just like, this isn't what she's practicing. She's like, this is not what I signed up for, right?
Unfortunately, we're slaves to the corporatized medicine structure, and it's in everything. I mean, it controls everything. I mean, how many really independent doctors do you know? I mean, they're not many.
Right. It's tough.
They're all piece good workers on the plantation of corporate medicine. And that affects training, the way people think about things, the way people take care of their patient. It all gets driven into monetization of the poor patient, which I'm hoping that your generation is going to make a difference.
Right. Well, I think, it's good that we follow evidence and we really do try to structure it. But I also do, I try to keep an open mind myself, right? There are some things.
Evidence-based medicine, though, it's a fraud, okay? So beware. The evidence is that evidence-based is basically just more of the same. It's a control mechanism.
Right. But you gotta start somewhere, right?
Yeah,
you have to have an idea. And it's only not evidence-based because yet until we have more research. And so it has to start somewhere. So thank you for being inspired and sticking with all of your passions and interests in the field, because it seems like it's finally boiling into reality. Like other doctors are we're not just seeing the evidence in published research, but now we're getting it in
I don't know
people's
if
hands.
you've seen the movie Elysium. Are you familiar with that movie? A science
I think
fiction
I
movie?
have.
And they have a healing bed or a med bed up on the satellite.
Yeah, I think Matt Damon's in it, I think.
Yeah. I think that's within reach, and that would be a light-based device, actually, which would scan a body and determine the defects, basically, and then correct it with appropriate light.
That would be a dream. Just to kind of go back into like specifically eye treatments again, there's a lot going into dry eye. There's certainly AMD. I hear some people online, various podcasters, they'll often throw out like, my vision improved. And I'm always frustrated because I'm like, to an eye care professional, I'm like, well, what in your vision improved, right? Because if you had macular degeneration, then maybe best corrected visual acuity, the ability to read down the chart improved.
Contrast sensitivity does improve.
Yeah. Right. That's what I think I've heard the most is color contrast, especially for people who are getting into 40 and above, perhaps, that if their mitochondria is not functioning as best, just like your muscle shell, you start to develop sarcopenia as you get older.
Well, and you would expect that, because basically what you're doing is you're pumping energy into the cells to make them work at a higher level. Unfortunately, we're all fading away from entropy and hypoxia. So if you can kind of bump that a little bit every now and then, you might last a little longer.
So I think realistically, for a lot of people who may be listening in, I think a big message would be like, if you have heard things on the internet that suddenly your vision's going to improve with this, it may not be the case. If you're over the age of 40 and you want to kind of dabble in it, or look in or talk to your doctor about it, if you don't have a disease, then you might notice your color or contrast acuity improve. It's tough to measure unless you're in an eye clinic.
The other thing I'll do for the ladies out there, and some of the men too, but it'll reduce wrinkles, eye wrinkles, eyelid wrinkles.
Right. I have some publications in one of the lectures I have that emphasizes the reduction of crow's feet.
Yeah.
Which is great, because then it's like, hey, you don't need to rely on eye creams and whatever else. You can kind of think about getting one of these devices, and you kind of get treatment of both at the same time.
Absolutely. Yeah, they can be cumulative and have some synchronicity with other treatment modalities. Yeah.
And then, at least in the eye care space, there are also you said glaucoma. There's some studies on glaucoma. I think some other genetic conditions like retinitis pigmentosa.
RP. I actually had a couple of RP patients. I let use the generalized, and it seemed to. They felt like it helped them see better. I couldn't document anything, but they thought it helped enough that they kept coming back to use this device. Now, whether that was just driven by their own situation, but it needs to be formal studies done, and that could be done. All it takes is money, which I don't have at this point in life.
Time and money. As far as, again, all these, I know it's anecdotal. You've said like anecdotally that, some RP patients felt like it helped, and that you used it a little bit for glaucoma. Are there any other like conditions or positive things that you've seen?
Yeah.
Again, maybe
I used iritis, herpetic keratitis. Man, one treatment will reduce the pain unbelievably, and speeds healing, probably cuts it in half. So, and iritis, you don't need as much steroid with it.
Yeah.
So
and
that
was this using the yellow light device you had it early on, or is this?
This was using red. Using red.
Okay.
Yeah. Like a early warp 10 kind of thing. This one I had custom made. It's got a little bit of near infrared in it too, like 890 or something.
Is there now with red light? There's some devices I've seen that are like 630 nanometers. There's other ones that again like are 650, 660, and then some that are like around 670.
I don't think within a 50 nanometer kind of spread it makes much difference.
Okay.
Frankly, a lot of that is determined basically by the LEDs that they can obtain, because they're only available in specific kind of wavelengths unless they have them custom made or something. And that's cost prohibitive usually. So they end up getting an off the shelf 660 or 670 or whatever it is and plug that into their device. So that's why you end up with this kind of discrepancy. And I don't think there's a nickel's worth of difference between 630, but at least 650 and 670. They're just, I'm not sure. You get down to 630, I still don't think there's any difference really in effect, because it's too broad. The treatment curve on the thing is pretty broad. It's not real narrow. It's not as narrow as like a laser.
That's really insightful, actually, because I never thought about that. I always sort of assumed that there was some hidden research around 670 or 630 that I couldn't uncover why they chose that wavelength.
I think it's I think the original basis for it really was Mester's work in the early 60s, and he's the ruby laser to speak and showed that it increased wound healing, it grew hair. And so I think based on that, everybody got the idea, okay, this is the wavelength we need to be around 660 or 670, whatever ruby lasers are. I think they may be 660. So following that, LEDs come on the scene 20 years later. And, and then they're much cheaper and they're safer because you don't get this collimated, coherent beam that can give really high energy densities and thermal issues and all that.
So like you said, for devices, you have the Aruna light that you use at home maybe a couple of times a week.
I do that. And then I've tried everything. I got, this is a useful thing. It's a Hugel light. Have you seen this? You can get it on Amazon, but this is for aches and pains and joints, muscle aches and pains. And it works. It's really pretty good, pretty neat little device. So,
interesting.
And it's cheap. Well, I want to say it's $70 or something. There you go. See?
Wow.
So if you got a sore joint, muscle, whatever, 5 or 10 minutes, you can really get, and it'll penetrate pretty good. You can see through my hand.
Yeah. There's just evidence, right, that the light does pass through your tissues. Goes deep through. As I say, as I review this and think through some of the notes that you've shared, and I kind of touch up even my own lectures on photobiomodulation.
Sure.
I'm sure I'm going to have more questions. So, and we'll probably get a ton of questions in the comments. So I imagine we'll be able to invite you back on, and we'll have maybe another big discussion about it. But is this kind of any final thoughts that you had about either safety, warning, or even encouragement, especially for professionals who may be listening in?
Well, I would encourage ODs and MDs that are in practice to not just dismiss photobiomodulation as a useful tool to help patients, because it's coming, and it's the biggest hurdles to it are our fellow colleagues and the regulatory stuff in the U.S. So, and regulatory stuff brings a lot of financial needs. So you have to clear all those hurdles, and you have to convince your colleagues, yeah, this is legit. Be circumspect in adopting anything new, but photobiomodulation is a real tool that's coming, and we have several devices already that actually have earned FDA approval. And so that should be some support to physicians and optometrists that want to get into using these devices. I always thought it'd be a great device especially for an optometric practice, because you're kind of limited on what you can do to patients in most states. So here's a way to non-surgically help folks out, and maybe keep them from needing surgery down the line.
Right.
So could be a useful tool.
So as far as the safety, like we kind of reviewed some of the, at-home devices, if it's not specifically marketed for treating the eyes, probably best to not shine it directly into the eye.
Right. And laser devices in particular, if it's a laser-based device, just be careful around that with an eye. I mean, even I don't have one up here. Normally I've got a laser pointer here. I'm using it with a cat, but
those you can hurt the eye if you stare into that.
I mean, you can blind yourself with that and those are really low output devices. But if you get that focused through a lens or you stare at it a long time, I mean, you can, just like a solar burn, you can damage your retina for sure.
Well, thank you again so much for spending some time with us and sharing so much of your knowledge, your story. This has helped me a lot for better understanding and getting an idea of kind of answering some of the questions that come up. I've given a few lectures on kind of introducing this to other doctors of optometry, and so that they're kind of, they've maybe heard about it, so at least they have fundamental idea and knowledge and resources of where the research is at.
I think it's important for ODs to know about it because, I mean, optometry are already using a bunch of diagnostic devices, which basically are probably doing phototherapy. We just don't know how to do that. But, you've got
OCT and even autorefraction uses some level of infrared or near infrared light. Yeah. That's essentially what it's doing.
So that's probably having some physiological effect, But nobody's ever studied that. It'll be a good study project.
And we've been doing intense pulse light, IPL, for dry eye for longer than that. Some doctors have been doing it for like 15 years, and it finally got FDA approved for dry eye like 5 years ago.
I think
that does have some photobiomodulation effect.
Yeah, you probably don't need the IPL part of it. I used IPL for cosmetic stuff when I was into that, but you can probably achieve much the same effect with a photobiomodulation device, which would be safer too and less expensive.
Yeah,
because IPL devices can be pricey.
Right now, there's like 2 or 3 publications that have either done an IPL versus low-level light therapy in like one population. And I'm hoping we'll see more publications kind of doing back-to-back.
It'll be interesting to watch what happens.
Yeah. But again, from here, thank you so much for jumping on.
Thanks for the opportunity, Joe. If you have any questions or I can help, let me know.
You're amazing, man. Thank you again.
Very well. Stay safe. Thank you. Bye-bye.
You've been listening to the Dr. Eye Health Podcast with Dr. Joseph Allen. For more resources, trusted information, and helpful tools, visit dreyehealth.com. Thanks for joining the community that's focused on healthier eyes and a healthier life. Until next time, stay informed and keep your vision sharp.